Good afternoon. My name is Dr. Susana Palma from Spain, and I am going to show you a case of unilateral posterior crossbite in mixed dentition. This patient is an 8 years old with unilateral posterior crossbite on his right side and anterior crossbite of 21, with skeletal class 3, maxillary hypoplasia, and right side mastication. When we analyze the face, we see that the patient has a good labial competence, a low smile, with some compression on the upper arch. So we can see the right buccal corridor wider than the left. When we analyze the intraoral view, we can see the anterior crossbite and the posterior crossbite on his right side. Every time that we have an unilateral posterior crossbite, we need to check the midlines of the patient at the first occlusal contact and with open mouth and in-centric relationship. In this case, in this patient, both midlines were totally centered in maximum intercuspidation and also in centric relationship. So we know that in order to make the correction, we will need to make an asymmetric expansion on the upper arch. We have also lack of space for 13 and 33, as you can see in the X-ray. And in the cephalometric pattern, we can see that the patient has a normal diverging skeletal pattern with skeletal class 3, with maxillary hypoplasia and lingual torque of upper and lower incisor. When we analyze our clean check, when we asked the CAD designer in the first place, it was just to correct the anterior crossbite of this 21 in order to avoid the premature contact that the patient was presenting in between the incisor, which could create a recession in the lower incisor. We are going to be asking also for the expansion on both sides at the same time that the mesial out rotation at the labial root torque of the upper molars. In the upper arch, as I was telling you before, we need to make an asymmetric expansion on the upper arch. So I am going to ask for more expansion on the right and less expansion on the left. And we are going also to make different velocity of the expansion on both sides. Remember always to make the rotation movement of the molars at the same time that we are doing the expansion. What attachment are we going to use? Well, whenever we are going to correct a unilateral posterior crossbite, we need to check the clean check from the back part, from our neck, okay? And we need to check if the CAD designer at the end of the treatment is engaging perfectly the palatal cuspid in their pits. So we are going to ask for this overcorrection of the labial root torque of this molar during all the expansion movement. Normally, the attachment that the software are going to place are going to be optimized attachment that has this bevel to occlusal and that is going to prevent the flaring of the molar during the expansion. In case that we are not provided with this optimized attachment, it's better that we use an horizontal attachment beveled to occlusal, because in that way, the moment of torque of this molar is going to be equal to the force by distance. If we use the bevel to gingiva, this force that is created by the contact in between the aligner and the attachment is going to divide into two different forces, smaller than the first one. So the moment of operation, the moment of torque of this molar is going to be more reduced. In the lower arch, we need also to create compensation to correct the posterior crossbite, because the patient that is only using his right side for mastication has a bigger transversal development of the lower jaw in this side. So we are going to ask for compression on the right side of this patient, and we are going to ensure at the end of the treatment a square shape in the lower arch in order to have contact in between the incisor at the end of the treatment. We need this rubbing on the incisor on the lateral movement in order to stimulate the maxilla, the growth of the premaxilla. In the frontal view, we see that the patient is correcting this anterior crossbite, and in the clean check, it looked like one incisor is going through the other. So we'll have to ask the patient just to be using the aligner for eating his food during the correction of the anterior crossbite. You can see the evolution of the patient we use at first an eruption compensator for the 12. And once that we have the lateral incisor erupted, we are going to re-scan again to grab it. This is the final correction that we can see how we have corrected the posterior crossbite, applying, controlling perfectly the torque of this upper molar. And so you can see here the correction of the posterior crossbite and the anterior crossbite. This is the different abrasion in between 53 and 63. The evolution on the upper arch, initial and final, with the transversal expansion in the upper arch. And this is the final smile of our patient. We can see that we were able just to make a space for 33, and as there was a lack of space still for 13, we are going to remove this temporary tooth in order to. And always remember that after we finish the correction, we need to stabilize the masticatory angles when the patient is doing the dynamic of the mandible to the right and to the left. We need to have at the end of the treatment a bibalance alternate mastication in order to be able to maintain the correction that we did with the aligners. So just for you to remember, every time that you have a growing patient and you have to correct to make a transversal compensation in the case, please decide carefully at the beginning what type of expansion is going to be more adequate for your case. You are going to use the first, the simultaneous expansion pattern, or the asymmetric pattern with differential anchorage, which, in my opinion, is going to be the best one that you can use when you have a patient with unilateral mastication. We'll need to overcorrect the labial root torque of the molar in all the expansion movements. And for that purpose, if we don't have the optimized attachment, we are going to use horizontal attachment beveled to occlusion. We are going to overcorrect between 20 to 50% the expansion in this case. And we will overcorrect also the posterior crossbite, making some compression on the lower arch. As a retention aligner, we re-scan the patient before Align Technology close the case. You know that in first treatment, we have to complete the correction before 18 months. So before we have closed the case, we re-scan the patient and ask for additional aligners just for night use. We will leave some extra space for the eruptions of the upper permanent canine that will be bigger than the temporary ones. And don't forget always to make a dynamic rehabilitation of this patient, a functional rehabilitation of the patient, because it's very important to maintain the correction of the posterior crossbite, that the patient use both sides for mastication, not continue using only one side. Thank you very much.